All right, looks like we're live.
And we're live. Okay, so we have to behave ourselves now.
Hi, Cosi. Hi, Chris.
Hi, Greg.
Hey.
Dude, it's been a while since we've done one of these.
Yeah, I agree. A little break.
I know, it feels like a while.
All right.
Okay.
Ooh, see lots of people popping on board.
Yeah.
All right. All right, guys. Oh, there's the person who emailed me. Yay, they came. All right. Folks, good evening. If you guys can, hey, there's Bob from Florida. You beat me to the punch, Bob. Guys, if you guys want to kind of try out the chat section and send us a hello, just so we can know that everybody knows how and where to access it. Chat section is on the bottom of your screen, and that's how you'll be asking your questions this evening. So if you want to give us a shout out, there's Johnny V.
Johnny. Hello, Chrissy. Hello, welcome.
Yes, Sophia, there is a skeleton behind me. That's Bob. He's my snarky occasional model. So he likes to join in.
Fantastic. Susan, hello. Nice to see you all.
Michelle, right on. Nice to see you.
Great. All right.
All right.
My desk is a wreck, you guys. I'm going to move this over. So, how has Cosi been? We've been off this for a while, everyone, and I haven't got to talk to Cosi myself either. So, how you doing?
I know, it's been fun. Kids are back in school. I have a high schooler now.
Wow, no way.
What?
High school?
A high schooler with the attitude that goes with it.
Yeah, I have one of those, but he's in college. He just started this year, so that's it's all good.
Yeah.
They grow out of it.
Does he know what to study?
Oh, I'm sorry.
Does he know what he's studying, or is
he's going to the Culinary Institute in New York, and he wants it's a 4-year degree, a business degree, and a sommelier and a chef. So all those years making him cook with me, I guess gave him a little direction. I was like, go and be a PT, bud, or go to restorative care or something. But no, so no, you know that attitude. He won't listen to dad right now. Yeah. So I'm like, okay, you know. You'll not know how to pick a good wine, you know. So
well, the fact that he's getting a business degree to go with it, that's really smart.
Yeah, it's pretty interesting. It's a 4-year degree school there. So yeah.
Very nice. Hey, Kelly, glad you could join us.
Hi, Kelly. Right on. It's going to be CIA is in my neighborhood. What does that mean?
They finally caught up to you, Johnny.
CIA, like, are you in trouble, Johnny? Just let us know. I got bail money.
Yeah.
Yeah, we got you, man.
I've got a shovel and lots of places to hide. We're good. No.
Oh, that's great. Great.
All right.
Okay. So should we get this party started? I think.
Yeah.
Okay. All right. So thanks everyone for joining us tonight. I'm Chris Bacher with Vital Fit. The topic for the evening is 2 procedures for improving phantom pain. We've got a few giveaways, which is going to be super fun. So please put your questions and comments in the chat box so that we can get to all of those. And at the end, we're also going to have a nice promo for attending this evening. Our 2 fabulous facilitators tonight, Cosi Bioso has her master's in PT. She has a clinic in Florida. She's been in practice for over 17 years and has dedicated herself to individuals with limb loss. She's got an awesome show Wednesday night, Facebook Live, Cosi Talks. Check it out, 8:30 Eastern. Welcome, Cosi.
Thank you for having me here. I always enjoy doing these webinars.
You're welcome. We love you. Greg Menino is a certified prosthetist. He's been in practice for, well, 20. he's been doing it a while. He's a 2-time world champion, as well as a 22-time medalist in alpine downhill skiing, as well as an above the knee amputee. Welcome, Greg.
Thank you, Chris. Thank you, Cosi. It's great to be back on live again. Thank you. Good to see everybody. Hopefully everybody had a little nice summer break from us. And I'm here tonight as a student to learn from Cosi, and let's all interact and answer these questions. So thank you for having me.
Awesome. All right, guys, we're going to dive in. This is becoming one of my favorite topics to talk about. Those of you who have watched my show have heard me talk about targeted muscle reinnervation and also about RPNI, regenerative regenerative peripheral nerve interface. And I feel like every time I do this talk and I review the literature and review the content, I'm learning something new. And I'm definitely in the last couple of days, as I was reviewing things, a couple of new details popped up. So thank you to VitalFit for allowing us to do this show. So guys, let's talk about just a little bit of brief history, because it's going to kind of help you trace as to how it got to TMR. So long and short of it is the basic techniques of amputation really haven't changed a whole lot since the days of the Civil War, and even prior to that, right, guys? I was in St. Augustine not too long ago, oldest city in the United States, and when the Spaniards were there in the 1600s, 1700s, the technique for surgical amputation was the same, right? They go through the skin, go through soft tissue, take the nerves, take the muscle, bone, and then flap over, right? The nice thing is nowadays our anesthesia has gotten a whole lot better, and our ability to control infection. Okay, but the strategy is basically the same. In particular, how they deal with the nerves. Okay, so in a traditional amputation, the surgeon will carefully pull the nerve out, cut it, and then allow it to go back into the soft tissue. And when I mean soft tissue, I mean back into the muscle, back into the fat, just kind of tucked in there, okay? And as we're going to talk about a little bit more this evening, what happens is that those nerve endings, right, they're kind of flip-flopping around in the soft tissue, they tend to form scar tissue around it. And when they start to form scar tissue, it starts to cause pain, okay? Residual limb pain, yeah? So Greg, how often do you hear of patients coming in your clinic with residual limb pain?
Everybody seems to experience it. And I think I have to say like 95% of the patients that I talk to nationally are experiencing phantom pain or residual limb pain at some type of level. And the longer term amputees, they seem to, as they season in their socket, we seem to see it a little bit more. But like you said, in the past, they would just cut that nerve and let it retract up in the residual limb. And there's all this real estate that your brain is still looking for that's not there. So I was reading some papers on Stochastic Entanglement. So your brain's sending those signals, but there's nothing to, send that sensory impulse back. So we end up with neuromas, scarring, and discomfort, and even debilitating pain with some patients. So this is really interesting for me too, because I lost my leg like 20, I wish. Time flies. About 40 years ago, and it was traumatic. They basically pulled that nerve out, cut it, and all these years later, I even experienced it. Higher activities, things that stimulate it. But I'm really interested in this therapy of the TMR, Cosi. So, like I said, I'm a student tonight with you.
So guys, one of my favorite sayings is to say, idle hands make devil's work. My 4 kids hear that all the time. And that's the case with these nerves, right? These nerve endings, they're just hanging around in the soft muscle tissue and they're not doing their jobs. So they start causing trouble. So that's where the TMR surgery comes in. It gives them a job to do. Okay, we're going to get to that in just a minute. So we're going to kind of veer a little bit and start on the upper extremities, amputees. And the reason is because TMR has actually been around for a little over 20 years now, right? But as we see a lot with our technology and sometimes with surgical techniques, it usually starts in the upper extremity amputee and then trickles its way down to the lower extremity amputees. But this surgery was made for the upper extremity amputee. And here's why, right? And Greg, you're going to be jumping in on this part. There's 3 basic designs for the upper extremity amputee for a prosthesis. You have your cosmetic, which is exactly that. It's just an arm meant for cosmesis. There's no function to it, right? Then you have your bodied power prosthetic devices for the arm. And that's where you'll see like a functional hook. You'll see the person activating it by moving their shoulder. In the case of a below elbow, they might be moving their muscles here to activate, open, and close the hook. And then you have the myoelectric, and some people like to nickname those the mind control prosthesis, right? This is where TMR comes into play. Greg, you want to add anything to that?
No, you're exactly right. I think when you have shoulder-powered prostheses, they're not relying upon an impulse from the muscle. So what we have seen over it's been probably 20 years now when they brought out the first myoelectric systems to the most current stuff available today. They function better. Patients do better when they have, TMR or electrode pickup, and we tried that a long, long time ago prior to the surgeries by putting placement electrodes in the prosthetic foot that would stimulate, almost like give you a shock inside of the socket that made you aware that you were on your heel or on your toe. So it's pretty interesting that you get the most out of a myoelectric device when you can actually fire those muscles in those nerves and think about it, hand actuates, elbow actuates. So.
And I just want to give a shout out to Bambi because she's actually an upper specialist. And
Bambi, good.
She's with us
Oh my
tonight.
gosh.
And I just, well, I love her and I want to say hi. And she's an upper queen. So super excited
Ooh.
that we're talking about this. So
Okay,
Good, Bambi.
no pressure, Chris. Bambi, I am a huge fan of yours and I've been wanting to connect with you for a while now. So if you get the chance, send me an email after this is over. I'd love to connect.
Great.
So now you're telling me this is, I'm trying to explain how this works. That's good, Chris. No, I'm kidding.
Pressure's on.
Right. So let's bring Bob into the picture and he's going to help us explain this a little bit. So for example, guys, if a person who has a shoulder disarticulation, meaning they are completely missing the entire arm, right? There might be a little bit of soft tissue left and they still have their nice big pectoralis major muscle. But for all intents and purposes, it's useless, right? That pectoralis muscle, it can't help them move anything. So what the surgeons do is it's kind of like an electrician. They go in and they cut the connection to the pectoralis muscle. I think it's like medial pectoral and lateral pectoral nerves. Did I get that right? Okay. So they cut the nerves that go to the pectoralis muscle. So now the muscle is a free agent, right? Then they take the nerves that are left, the nerves that used to control the hand, the elbow, and the shoulder, and they plug it back into different points in the muscle. And the nice thing is because it's such a big muscle, they've got a lot of things to play with right there, right? So in the top part, they'll put the nerve that helps to flex the shoulder, right? And in the bottom part, they'll put the nerve that extends your elbow, that extends your arm as well. So it's kind of intuitive, the way even they put the nerve placement, right? So then when they put that myoelectric prosthesis on, the patient learns how to activate those nerves. And what's cool is it's more intuitive. So the patient basically through a process of lots of therapy with folks like Bambi, right? They're going to learn how to activate that nerve that flexes the shoulder, and the shoulder, or at least the elbow, will bend in the prosthesis, right? They're going to learn how to activate that bottom nerve that's going to help extend the elbow or open the hand. So it's more intuitive, it is like a mind control. So Greg, have you seen any of these?
I've seen, I was just at AOPA this week with Chris, and we were over there looking at different companies, and this CoAdapt company's got some really neat technology on, the way I gather it, it's more sensitive sensors that pick up these muscle impulses. So, but like you said, I think it's training those amputees once they plug it into flexing your pec, flexing your deltoid. And they even do it in the back, right, Cosi? They plug them into your lat muscles. Coach me a little bit. Come on, Bambi, you got to coach me. I'm learning too. But yeah, go ahead. I'm sorry.
Well, it literally looked like mind control. So he inserted his arm and it did a test run to set, and then he literally thought things, and it happened. I know that's not very intelligent speaking.
No,
but it was amazing.
Yeah,
it was amazing.
And in some places like Europe, they have almost like a virtual reality of visual biofeedback. So they'll sit the patient in front of a computer screen with the image of a hand, right? And they'll have the patient connected with those same electrodes. And then they'll basically, the patient basically has to use, Jedi mind trick to try to open the hand. And then they'll get that feedback from the computer, seeing the hand open and close. And then they can translate that to when they wear the prosthesis. So it's really fascinating. And one thing I did learn also is that the people who have used, who've never used a prosthetic device before have an easier time learning the myoelectrics because their brains have not learned any bad habits or new habits. And the folks who've been using a body-powered prosthesis, their therapy just takes a little bit longer because they're having to basically retrain their brain on how to operate that prosthesis.
Great. So interesting.
So I think we should do a giveaway.
Let's do it.
What do you think?
Yeah.
Okay.
What am I getting?
We got a cool travel kit. It's got a nice, generous portion of all the products. And so Jamie's going to, well, look at her go.
Here we go.
So Jamie has put the link. So please click on that and let us know the first couple words of the title of our first blog. And we do this just because it's fun, because I love to give stuff away. But also we try very hard to support the community with information and support. And so just FYI, check out our blogs, and I think you'll enjoy it. Oh, and it's a random draw, sorry. So Jamie's gonna pick somebody out of a hat that she's got sitting next to her desk.
I think that sounds good. Can't be quick to the gun. So I got a question while we're waiting for that rabbit out of the hat to Bambi or Cosi here. And maybe Bambi, because she's on here and she's working in this daily. Do you find it easier to train your new user, like Cosi said, or your seasoned user who's had the habits of power and or? So I will put that question out there. I'm just curious again, this is we're learning all the time, and I'm fascinated by the devices they've developed for upper extremity amputees, and then how this is going to trickle down to our lower extremities. So, so any question, not to put you on the spot, anybody, but
we'll put her to work. That's fine.
yeah, we're gonna have everybody. It's pretty interesting.
All right, so we're gonna give you guys a few more seconds. All right, we got an answer from Michelle.
Win a free travel kit.
Love the bait. Awesome.
Oh boy. Okay, here I gotta look at the chat. My chat keeps jumping down, so I'm not seeing it. Okay, let's see.
So no worries. Proceed, my fabulous facilitators, and then we will announce the winner shortly.
Okay.
So guys, we talked a little bit about the history behind TMR and where it came from. So I haven't really looked up to see who came up with the idea of, let's try this on a lower extremity amputee, and oh, look, it's helping with neuromas, okay? So basically, you know, when patients come in to see me, 9 times out of 10, they have some form of pain or sensation. It's either phantom limb pain, phantom sensation, or residual limb pain. And we did a huge show on this, and it's on the Vital Fit webinar site, where you can see the show that we did just on phantom limb pain. So we're just going to kind of quickly go over it. And for me, it's really important to understand the difference between those 3 terms. First of all, it's the phantom limb sensation. So it's exactly that. You are able to sense your foot or where it used to be. Okay, so the foot's no longer there, but you're feeling it. And usually my newer patients, they think they're going crazy, and they come to me and they're like, I can feel my foot. I know it's not there. And it's like, no, you're not crazy. That's just your brain trying to figure things out. But there's no pain. It's just a sensation, right? Versus the true phantom limb pain, where it's exactly that. It's either a stabbing, a burning, an aching, a crushing. How many other adjectives can I come up with here, Greg?
Pain. I think those 3 are the ones. It can be debilitating, and it's not, I giggle, but it can interrupt your life, interrupt your prosthetic use. And it's no fun for anybody. And it's interesting enough, even myself, when I think about it, then I get tingling sensations, because again, your brain's sending that impulse down there looking for a sensory, input from your toes, your feet. And the one term, that Stochastic entanglement thing, and because you're missing real estate and your brain is trying to figure that out. So yeah, all the time.
Yep. So you have your phantom limb pain, and then you have your residual limb pain, and that's pain that's originating in the limb that is still present, right? And that can be due to many things. It could be due to muscle strain. It could be due to a cyst. It could be due to bone spurs. It could be due to a neuroma. Now, some of the things that are causing your residual limb pain can also be triggering your phantom limb pain, okay? And that's where the art meets the science, and trying to puzzle out, okay, what is causing what, and what is it that we're really seeing? And this is a conversation I've been having with one of my viewers this past week, and trying to kind of suss out, where is this pain coming from and what is causing it? Because unless you know what's causing the pain, you cannot treat it properly, right? All right, Bambi just sent in an answer and I want to read this. So Bambi says, new users for sure, but with all the technology of muscle site testers and virtual reality, there are so many tools. As long as we can work on EMG, electromyography, which I love, we are golden. Okay, thank you, Bambi.
Thank you.
All right.
Answer.
So in the case of a neuroma, guys, okay, remember what I said earlier on in the talk, right? Nerve's been cut, goes back into the soft tissue, and it starts to form scar tissue around itself. And it doesn't have a job to do, especially if it's a sensory nerve. If it's a motor nerve, you'll get scar tissue around it and you won't feel it. But if it's a sensory nerve, right, you're going to feel it. And it's usually a very sharp pain, a burning pain, right? That's usually what I hear from patients. It's a very burning pain. It's nerve pain. So it hurts, right? And usually with my patients, if I take my thumb and I kind of just jam it in where they're feeling the pain, they'll see stars. They hate me for that, but that's a huge indicator for me. Like, okay, we really need to get this person evaluated with either an ultrasound or an MRI to see what's going on. So Greg, how do you typically see your neuroma patients when you know?
Well, same way. We try not to manipulate it too hard, but a lot of things, like you said, activity, dehydration, things can exploit that neuroma. If your hydrostatic pressure of the socket's too great, that can do it. If you've gained a little weight, that can do it. So we see a lot of different things directing towards that I try to avoid going in there and prodding too deep. We know how you can light people up, but again, I've seen, some cases where the sockets are just so tight on them that, they put on too many socks or they've gained weight that really stimulates this. So again, it goes back to, activity, hydration, and trying to keep your weight the same as an amputee. I think that's really important to reduce this scenario. So, but yeah, I don't know if I use what you do. I don't probe too deep with my thumb.
Well, I'm not, okay, that sounded really horrible, but basically, I'm a physical therapist. We're handsy people, right? So whenever I'm examining a residual limb, I'm feeling all the different parts of the limb and I'm feeling to see how the scar is moving. If they have any sensitivity, especially if in my below the knee, I had one young man come in this week and his tibia bone is just basically sticking out. So just kind of, pushing up on that and just seeing, okay, is that's what's causing his pain, is because his tibia bone doesn't have any soft tissue on it, or is there something else? And then usually if they've got a decent sized neuroma, if you just get anywhere near it, you'll zing it, right?
No, right.
So
Cosi, don't worry. We know you're not a masochist. I probably shouldn't have said that. But I want to say shout out to Chrissy. Congratulations, travel kit. So Jamie's gonna put my email in there. So please give me your address so I can get that off to you. And thank you so much for being here tonight.
Thank you for being here, Chrissy.
Thank you.
So guys, the first thing is diagnosing the, where the residual pain is coming from. If it's a bone spur, there's one way of treating that. If you've diagnosed a neuroma, like Greg mentioned, a lot of things that you first do is the conservative methods, okay? How can the socket fit be adjusted? Is it too tight? Is there an area of pressure that needs to be relieved? Can a polyurethane custom liner, be enough to help relieve that pressure, or maybe even a gel liner, Greg?
Right.
A little bit more of a cushion ride.
Sure. The best thing about the liners available today are there are different degrees of firmness, maybe, to put that, but most guys, you can relieve the socket, you can push that out, you can cut the carbon fiber, whatever it takes to get the pressure away from it is what we try to do. So, because if this is debilitating and interrupting your prosthetic use, we all know that patients become more sedentary, and that's not good too. So relieving the socket, reducing the liner, in some cases increasing the pressure too. So if the socket's too big, you're bottoming out, transtibial, transfemoral, that can stimulate those neuromas as well. So we want to, like Cosi said, evaluate, try to figure it out, get our head wrapped around what the plan is. So, and that's where Cosi with the TMR stuff comes.
Yes. And guys, there's other, I've heard some folks who get injections, pain injections, but sometimes they don't last very long. So it goes to the point where there's a recommendation for surgery. And usually by the time it gets to this point, it's because it's interfering with daily function, right? And the person is in constant pain. Like I said, the young man I just saw this week, he's a candidate right now for that as well. So the traditional method has been just to basically go in and resect and carve out the neuroma.
That's it.
But what happens is when you close the person back up again and they start healing, there's a high tendency for it to come back. Why? Because the skin or the body heals itself by forming scar tissue, which is what caused the problem in the first place, right? So remember my saying, idle hands, devil's work? With TMR, you're basically putting the nerve to work, okay? So basically they take that nerve ending and they plug it into a specific motor point in the muscle, right? So there's a special little machine that they use to find just the right place in the muscle where the nerve ending will be accepted, right? And they graft it into there. And what that does is it allows the nerve to start spreading out little nerve rootlets, right? And getting embedded into that muscle. And it makes it a lot happier. So that's the basic gist of how the TMR surgery is done. The recovery process is very similar to after, any kind of revision. 2 to 4 weeks, maybe a little bit longer, depending on how the wound is healing and how the soft tissue is doing. And if you were using the prosthesis prior, then you can go back to using the prosthesis usually by 6 weeks afterwards. Your surgeon will clear you to go back. Yeah. So Greg, do you see a lot of TMRs come in through your clinic?
No, that's a no. It's kind of new. And I think, like you said, people have gone in for revisions. Actually, I know one patient, that's not true. And she had a very good outcome, but her rehabilitation was quite longer than we thought. But in the past, the revision people, it's, not a pleasant thing to go in there and have them get in your residual M, but they used to just cut the neuroma out and, it would retract, and we still are missing all this real estate. So it reoccurs. So I think today, if you're looking at revision or looking at amputation, it's absolutely no question that you find that surgeon who can actually plug in these nerves in the TMR. So.
And this is a question that came up when I did the show. I had Dr. Leonard Dedesi. He's an orthopedic surgeon up in Pennsylvania. And he is very well versed both in TMR and RPNI surgeries. So he gave us a lot of great information. So a lot of this information is coming directly from what I learned from him. And he mentioned, because I asked him, I go, well, is there a statute of limitations as to how long you can wait before you have this done? And he said, no, basically the best time to have it done, the ideal time is when you have that first amputation, right? If you're somebody that you're going to be facing an amputation, then you have time to do a little bit of research, find that surgeon and get it done at that moment. Those are the folks that will have the best outcomes. And then the further out you are, I believe he quoted me, 18 months is kind of the sweet spot, that if you can get a revision done within 18 months of the first amputation, that's when you're going to see the best results. Okay, now it's not to say you don't see results. In some of the literature I was reading today, they said, no, absolutely. If a neuroma is causing the debilitating pain, causing loss of function in life, even if they are years out of their first amputation, it's certainly worth getting a surgical consult. There will be an improvement of some sort.
Absolutely. Yeah, I sat in on your show with Dr. Adazi, and it was pretty interesting. I listened in on that because I'm still learning about these techniques that are available, but it's no question you want to have this done or find that surgeon to seek it out. It's just if you're facing like a lower limb or a below knee amputation, to get a hurdle procedure too. So cool thing is, Cosi, that gal I referred to you is researching all this prior to amputation. So she'll get some great information and have it done. It's no question in my mind now. So.
Yeah. And this is something, folks, that even for my patients that are having a revision done, that's not related to a neuroma. So patient, for example, who had way too much soft tissue at the end of their residual M and it was impeding their socket function. So that's why they were going in for revision. I was definitely squeaking the wheel and saying, while they're in there, right. Okay, you're already opened up, right? Get the TMR done, right?
That's huge. Yeah, good point, Cosi. That's fantastic.
It's almost a no-brainer. And it's basically, when you ask the question, well, who's a candidate? And it's like, well, who's got a neuroma? Who's got loose nerve endings, right? So it's certainly worth, I always say, it's a free first visit. It's always worth getting that consult done with a surgeon who knows what they're looking at. And again, just thinking back to the viewer I've been chit-chatting with this past week, one thing I was stressing to her was saying, make sure you go to someone who knows what a neuroma looks like, right? We have phenomenal doctors out there, phenomenal surgeons, but not all of them have worked with amputees. Not all of them know what a neuroma looks like in an amputee, right? So
Right.
you want to find the surgeon who has seen it and who can correctly diagnose it, or they might tell you, nope, not a neuroma. This is what you need to look for,
Right.
right?
Good point. Yeah, that's huge. Yeah, that's huge. So do you have a list, Cosi, of TMR specialists in this country? I was
I
kind of
do.
baiting me on that question to ask you. So
Yes. And guys, I just posted this really wonderful link. Okay. Right click, open it up on a different tab so you can read it with your coffee tomorrow morning. This particular company, I'm going to give them a little bit of a shout out. Checkpoint Surgical is a company that manufactures surgical devices. And one of the surgical devices that they make is used in TMR surgeries. And they provided me with this link, which has a directory of all the surgeons in the United, well, not all of them, but a very extensive directory of surgeons who have trained for TMR and RPNI procedures. Okay, because I know I get a lot of questions about that. Is, even though the procedure's been around for 20 years, surgeons are still catching up to the game here. And again, oh no, it wasn't sent to all. Thank you for letting me know.
okay, yeah. Maybe try reposting it. Awesome. Yeah.
Let me
Again,
check.
that's a wonderful thing about these. Yeah, I'm sorry.
There we
Go ahead.
go. There we go.
There it is.
Yeah?
we go. Okay. Yeah.
Okay. And for my clinicians who are out there listening right now, if you go to the Checkpoint Surgical website, a lot of great papers and abstracts and videos on TMR and RPNI surgery as well. So it's a really nice place to get information. All right. Are we ready for another giveaway?
Yes. Like
Yeah.
my turn, right? Because I'm good at that. Okay, so we got another travel kit and Jamie is going to plug in the link in the chat box. So please let me know the first word or two on the video, because we've got awesome videos since we've been doing this. Wow.
A little over a year now.
My fabulous facilitators. Yes, a year's worth of awesome information, all embedded in that wonderful link that she's sharing. So again, she'll draw us from a hat and I'll let you know soon.
Okay. Awesome. Awesome. Okay. We'll
All right.
see that going on. Really interesting stuff. And I think that's the most wonderful thing about VitalFit sponsoring these, Cosi and you, is you just shared a link that's so helpful for everyone out there. And what we've tried to do in the past and all the blogs that VitalFit does, thanks to Jamie and Chris, there's so much information that'll help patients, and you just need to go out there and learn where it's at. And I think that's kind of inherent to some people, maybe some prosthetists. They don't go searching, they get caught in their ways, but it's fantastic to be able to be a part of this and learn that stuff. So thank you for that link, Cosi, because I'll be on there. So awesome stuff.
Okay. While you're on the VitalFit website, show them some love, looking at the blog section. They've got a lot of great stuff on the website. I'm always sending folks there to go read the blog and watch the videos as well. So a lot of really great information.
Yep.
We are live. Oh, sorry. I was like, we are live. Yes, we are live.
Yeah, we're live. We're live, baby.
Responding.
Okay. My desk is red. So the PNS stuff. Come on, talk.
Yes, the RPNI. Let's
Yeah,
talk
RPNI.
a little bit about RPNI.
Okay.
The Regenerative Peripheral Nerve Interface, and I still have to look at it because I make up different names for the acronym all the time.
I do the same thing.
Anyway, so basically it's like the sister to TMR. The goal is the same. It's basically taking the nerve ending, taking a little piece of muscle graft and wrapping it around the nerve ending to basically just kind of encase it there, right? So the nice thing is when you take that nerve graft, you're automatically severing that little piece of muscle from all its other previous ties. Because remember, guys, it's kind of like electrical wiring. If a muscle's getting information from one nerve, it can't accept information necessarily from an alien nerve. So they have to cut the connection. So when you do RPNI, you're doing that just by lifting up the muscle graft, right? Wrapping it around that nerve ending, and then the nerve kind of shoots out its little nerve rootlets into that little piece of muscle and all is happy. So the question is, when do you use TMR? When do you use RPNI? So
Right,
the answer, the answer Dr. Nadesi gave me was very typical surgeon. He said, well, when I open up the patient, I see what's needed and I go from there. So whatever looks best in the surgical field. When I did a little more reading, it sounds like a lot of times, especially if they're doing these kind of procedures in the upper extremity in the hand, they prefer to use the RPNI. It's a little bit less invasive from what I was reading.
Interesting.
But as far as outcomes are concerned, and you're going to have two camps. Apparently you have surgeons who are very TMR and surgeons who are very RPNI, and they'll throw statistics at each other. But the surgeons that do both, they say, you know, the outcomes are good for both, you know, as long as you're using the right surgery for the right patient. So this is something, you know, to bring up to your surgeon and just ask them which one they prefer to do and why.
Yeah, that's a good question. I think that's what I would do, because it gets a little bit confusing when you start searching it on Google, these two different techniques. I actually came up with one. It's a question, I guess. What I'm going to ask you, Cosi, is the peripheral nerve system interfacing. So I've seen a couple of different things where they're going in and putting electrodes on the nerve and then putting a pickup in the socket or wherever that may be to allow you kind of the same technology, but they're wrapping the nerves with stuff. And then I actually saw another company that was actually putting a sensor under your skin using a tunneling tool, wrapping the nerves with an electrode that you could interfere electrically, kind of like a pain pump or a back stimulator to stop that phantom pain. So there are other techniques that they're out there. But I think if you're going to go under a surgical procedure, I think I would be leaning more to RPNI or TMR than having something put in and trying to just maybe block that sensory nerve signal or interrupt it. What do you think?
Well, I think it depends. You know, the pros of having the TMR and RPNI is you don't have any foreign devices placed into
Right.
Right. There's no implantable device. And once you are healed, you know, things are good to go. The other side of it and I've had a couple of companies, you know, talk to me about what they're working on when research with these implantable devices. It's minimally invasive. Right. So it's a much less invasive procedure, a lot less, you know, you don't have the pain of having to go through a revision, but you have an implantable device, you know, you have a device inside your body. So how do you feel about that? You know,
makes me go,
you know, what are you a candidate for? If you have a lot of medical health problems and being under general anesthesia and having to be bedridden or, you know, long recovery period, that might not be a good idea for you, right?
Good point.
Good point.
Thank you for correcting.
No, but that's just my, you know, I'm with you, Greg. I'm a huge fan of the TMR RPNI. Whenever I hear somebody who's having a revision done, I'm like, you must do TMR and RPNI. You know, so I'm definitely a huge proponent for it, especially when the pain is debilitating, you know.
Right. It should be no question in anybody's mind. If you're going to have that revision, just go ahead and research and have this procedure done. Cut and dry for me, really. I mean, there's other things you can do if you're not looking and you're afraid. Like I'd be truthful, I'd be a little afraid to go and have the procedure just from the downtime in my prostheses and stuff. So there's a few other things. Cosi and I, we talked about the injection to calm it down. I guess if you're trying to figure it out, that seems very interesting to me. There's the radio frequency ablation of the nerves. So we could talk a little bit about that, but maybe right at the end, we'll bring that up on different avenues if you're not ready for that revision. So,
yeah.
And big shout out to Michelle. Congratulations on the trial.
Michelle.
And Michelle, I want to thank you for your support because I just love seeing you there and appreciate you spending time with us. So make sure you get me your address, and Jamie's going to put my email address in there. Thank you.
Cool. Yeah, Michelle, you've been on a bunch of these, so good. Very nice. So, okay. Yeah.
Okay.
Yeah.
Awesome.
Email Chris. Okay. All right, Cosi.
So, you know, going back to what Greg said, you know, and again, this is the, you know, if a person comes in and they're diagnosed correctly with a neuroma, it's not like, okay, automatically go to surgery. No, right. You know, obviously a lot of risks associated with surgery, a lot of downtime, a lot of things that can happen. So obviously trying some of these conservative methods first. And also they can also possibly help to see if the TMR is going to be a good idea for you. So I was telling Greg in one of the papers I read today, they did a nerve block. So they did a nerve block just a little bit above where they thought the neuroma was, and it was successful. The patient was pain-free. And then, you know, nerve blocks wear off as they tend to do, but at least they knew that they were on the right path.
Right.
In resecting and then plugging that nerve back in. So some of these conservative methods can also be diagnostic, and they can also kind of help predict how you might do later on.
Great. I think that's great. I think that is great. There's, I know I'm kind of a big baby when it comes to that. So I would be trying to look at conservative methods. But again, if you're facing amputation or this is debilitating, research TMR and RPNI. In my own case study, kind of bringing up now about the radio frequency ablation.
Yes.
So here's, this is really interesting to me. I've had some issues with my S1, L5, L4 back nerves, just pinched infringement from prosthetic use for 40 years from impacts of ski racing, you name it, plus age. A little decrepit, but I had this procedure done, and I could throw in where you can look it up, radio frequency ablation, and they went in. It's like almost an epidural, but they go in those sensory nerves and superheat them, so it basically scars them off, and you don't transmit or feel that sensory nerve sending pain back to your brain. So the most interesting thing for me on this is where I'm like kind of all like want to share with people is. My back pain was alleviated. I mean, I had phantom pain on my amputated side, but I was having peripheral nerve pain in my right calf from this, but it interrupted that pain signal, and I'm not feeling the phantom pain or the peripheral nerve pain on my sound side. So pretty interesting stuff to research too, everybody. I don't know, Cosi, what are you thinking about that? I sent you a couple links.
No, the ablation is something I've seen a lot of folks get done. And again, it's usually kind of the last end, one of those things that you try the conservative methods with physical therapy. And again, this is for mainly with folks with the 2 anatomical legs that we've treated. But yes, when the pain gets debilitating and the ablation, it's exactly that. You're basically just, you're cutting off the pain signal at the source, pretty much.
You're interrupting it, right? What's interesting is it supposedly, well, we'll see, and we'll talk about this in 6 months. Your nervous system regenerates that. So 6 months to a year, they say, oh, you might have this reoccurrence of pain, but and that wasn't the target for phantom pain, because I think, like we said at the beginning of the show, a lot of amputees experience phantom pain from maybe extreme sports, whatever that is, or just general activities, but it addressed some issues that I had no idea it would work for. So that's kind of cool. I mean, if you're really afraid of surgery, or you want to like be conservative, like Cosi said, it's something to look at, and I could throw a link in there if anybody's interested. So one of those other things to look at while we're doing this. So let me throw it in while you're making a rebuttal, Cosi.
No. All right, guys, now's your chance. Ask your questions. Don't be shy. Have any of you out there had TMR or RPNI, or any of you out there a revision? Possible revision.
That's a good question. Thank you for bringing that up. Is anybody, I would like to see some responses if anybody's done it. So again, I think when you asked me earlier, I've had one patient, she had incredible neuroma pains. Had to have two revisions, maybe 3, just going through, the gamut with this. And she had it done, and her rehabilitation was, I think, a little bit longer than she anticipated, but today she's just doing well. She's not having this debilitating prosthetic pain, but I think some of that was contributed to poor fitting sockets. So be in tune with your PT, be in tune with your prosthesis, be in tune with your surgeon, research these things, because if you're being interrupted by that simple thing of a tight socket, it'll certainly stimulate these issues. So think about that. And I'm going to try to focus on my keyboard. Cosi, go ahead.
No. And I don't know if it's because I've done the show on TMR, but I feel like I have a lot of viewers that pop up lately and they say, hey, I just had the TMR done. Hey, I just had TMR done. So it's interesting just to kind of follow them and just to see how their progress goes from there.
Good. Yeah. How do I get that to go?
Chris, there we go. Radio frequency.
All right. Yeah, that's just a name here. I'm trying to find, I go ahead and put it in, then it wants to go to a different site. So trying to find the best one. I got about 20 of these things because I did all my research on all of it when I had it done. So, but something to think about, I think. It may be able to help. It's pretty much like a 15 to 45-minute procedure. They twilight you or put you under because it's like a knitting needle kind of in your back. But but maybe alternative to surgery, especially like Cosi says, if you've got compromised immune or issues like that, something to look at. So.
And was it a neurosurgeon, I'm assuming, or orthopedic surgeon that did the procedure?
Well, they both do it. So orthopedic rehabilitation surgeon who did a restorative care. So I think it's those two guys who do it. It's not but it's guided with radio or X-ray, so they can pinpoint exactly where the nerve is. They do require you to go through 2 weeks of epidural, so to really figure out where that nerve is. So I mean, he went in there prodding around for 2 procedures prior to it, but that's part of what they do to see if you get relief if they're putting that epidural needle in the right place. So you got to endure kind of 3 procedures, but I think it may be not as invasive for sure as having a revision. But again, I think if you're facing amputation, absolutely no question, RPNI or TMR. So again,
yep.
Thanks, you got people to learn from. Thank you, Cosi. I'm a student tonight, so.
All right, Chris, you're on.
I am on.
You're
All right. I'm right on. Jamie's going to put a link to our survey. So please participate. And once again, we're going to put you in the hat. And we've got a full size for the winner of that. And please give the website a look. We are very committed to supporting the community. And thank you, Cosi, and thank you, Greg. Check out the blogs, check out the videos. Let us know your thoughts. My information is here. We're gonna show you a slide at the end as well. Twitter, face us, TikTok us. Seriously, I don't know what they all are, but please do that. And we appreciate your time very much. And I just want to say thank you again, Cosi and Greg. We appreciate you very much.
Absolutely. We appreciate you, Chris. Thank you. Thank you to Biofeedback. It's been a year of information, I can tell you that. And one of the silver linings of a pandemic is getting to work with Cosi and you and sharing the information, the love with patients and making friends. And we're all a big team here to see everybody's outcome be optimized. So I know that's why that lady right over there, what keeps her alive and makes her get up every day. So
thank you. Thank you.
All right.
Oh, there's another great one here. Somebody, before we go, we got to read that one. Oh, it's too Cosi from Bambi.
Okay.
You see it?
Yep. Bambi says, it seems that the patients who have TMR at time of amputation do great with pain, but those who have it later as a result of neuroma development seem to have such cortical pain postures that it continues painful. What techniques do you do to help these patients get through these pain times?
Ooh, good question.
No, and Bambi, it's something that I've seen a small handful of patients here in the Tampa Bay area. There is one surgeon that does TMR surgeries, and some of them, they get lost in the ether, unfortunately, and they don't get the proper follow-up. So when it comes with the pain, a lot of it is just seeing, okay, is there any, residual inflammation going on? And just doing the basic post-op techniques, do they need to wear the shrinker to help with that inflammation? How are they doing? Oh,
sorry.
Is it something that they need to get referred back to? It's one of those things where when they're still having pain after, and again, the couple of patients that I've seen after TMR, they've had good results. Even the ones that had it after their initial amputation. It was mainly dealing with the regular post-op pain, if that makes any sense. So, continuing to work on their inflammation and getting them up and moving and getting muscles strong to help pump out the inflammation. So I know that doesn't really answer the question too well. If I have a patient who's still in really debilitating pain, I refer them back to the doctor just to see if there's anything there that they missed, like an underlying infection perhaps.
Right, that's what I'm
just to see and make sure that everything is checked off. But unfortunately, Bambi, a lot of these patients, they get lost in the cracks and they don't make it to the outpatient physical therapy like they should. So that's something, one of the million reasons I do this show is to try to bring awareness to that. So
right. Great, and that's awesome. I think that anytime we're doing a TMR or RPNI surgery, we're really monkeying around with our nerves. And I think that's what you said, Cosi, on the one case study, is they put a nerve block above that neuroma. And I'm convinced if you have a bad neuroma, even under general anesthesia, that patient will jump off the table when you start cutting those nerves. So I think that there's a lot of manipulation. They're restitching. They're in there. So when we say, in a lot of research I did, it was like 2 weeks and you're going to be fine. That's hard for me to believe as a practitioner. I think you want to let that patient know we're looking at 4 to 6 weeks prior to donning their prosthesis again. It's just, that would be my own case study. I'm kind of a big baby when it comes to that, but just FYI, I think you've got it on the head there. I mean, in the past, we try to desensitize that residual limb, and I think people want to move and get back to life quicker. And I think, again, I'll state it again, when you're having nerve intervention type of surgery, it's going to be a little bit longer than you probably anticipate. So just be aware, everybody.
Yeah. And then Bambi, thank you for as far as protecting the limb, when you find that they have like the heightened hypersensitivity. So, with that, there is the brushing protocol. So I use that on my patients. If I can, if they're having just that sensitivity where, and now that, the brushing protocol. So guys, and I usually use this, I used to use this a lot with my original amputees. But it can be used for those who've had revision. So basically, when you're first examining a patient and you put your hands on their residual limb and they're like climbing the walls, not necessarily because there's a specific location of pain. It's just, they can't stand having someone touch their limb, right? Hypersensitivity. And this happens a lot with the newer amputees. We'll start what's called a brushing protocol. So I'll take something like a cotton puff, right? And I'll carefully brush it on their limb, starting at the bottom of the residual limb and working my way up approximately up to the top, right? And it only takes a few minutes, right? And just basically to get them desensitized to that soft touch. And then we progress, once they're able to tolerate a soft cotton puff, then we might do something like a terry cloth, washcloth texture, and maybe with some warm water to help kind of just alleviate that feeling. And again, just gentle brushing on the limb. And then I'll teach the patient how to do this. And it's interesting. Sometimes patients, they'll put their hands and they can tolerate their own touch,
right.
They can tolerate their own hands,
yeah.
But they just can't tolerate someone else's. So if that's the case, I might have their family member do this brushing protocol. And usually it's just a few minutes a day, 2 to 3 times a day to kind of start that desensitization process. So Bambi, if that's what you're referring to, that's kind of my preferred method. Also, if they can tolerate being in a warm bath, I find that sometimes also kind of alleviates that, and they can do massages in the warm bath while they're underwater, kind of just helps with that. Great. Greg, is this something that happened that you're?
No, I think I'm from your school of thought right there. Exactly. I think the underwater therapy takes that hydrobaric kind of, and there's hydrobaric therapy, right, as well. But when you're in the water, I think it takes off that gravity too. So that's a good thing. But again, I think everybody just needs to be aware. You're having a revision and it's going to be painful. And if it's extremely painful and continuant, I would be back at the orthopedic surgeon, making sure there's nothing infected in a deep tissue, because they're frankly go in, they're pretty deep. So be aware of that. If you've got redness or any type of fever or anything spiking like that, get back in there. But in the past, for what you're referring to, Cosi, they would like desensitization, hitting, touching, rubbing. But I think that's just something that we're going to probably see. Mm-hmm. I just saw another Kelly just popped up a question.
Yes. And John, to answer your pain, cortical pain posture is basically just the retraction from pain. It's like a flexion response. Right. Usually you see this in patients with traumatic brain injuries or strokes, that they'll have a response to pain that goes into flexion. So that's what that means. And then there was another question. Okay. Kelly says, I find graded motor imagery programs to be very helpful, especially getting to mirror therapy. Lots of core strengthening and addressing asymmetry as well. Yes, and yes.
And yes.
So definitely now, for me, and again, Kelly, love to hear your opinion on this one. When it's hypersensitivity, I tend to do the brushing and the manual type touch protocols. And then when it's the phantom pain, then I love Mirabox, and I love the graded motor imagery programs that they're coming up with nowadays. It's not to say you can't overlap and use them for both. It's certainly going to work. So Kelly, do you distinguish between the two, or do you stick to doing the graded motor imagery? Do you differentiate? I guess for lack of a better word.
Good question, right? We always, we did shows on Mirabox therapy, and we always kind of forget and overlook that. And before tonight's, I forgot I lent out my Mirabox, or I'd grab it, but normally it's right there. But I lent it out for somebody to give the shot. So, but that is another alternative to reducing pain on the interim prior to potential surgery. So again, I think that's really important. And I'm more interested in talking with your orthopedist who's doing the injections too, because I'd love to see what they're using, lidocaine or cortical steroid, or what they're doing there, because I think that could be helpful for a lot of people. But so good stuff.
And congratulations, Kelly. She's going to take the baton from Bambi. So big shout out. Thanks for participating tonight. We appreciate you.
Yeah, great. Good stuff.
All right, guys. And if there's any questions that you didn't think of tonight, or that we didn't get to, you can always contact us. And I know Chris is going to give us that information as to how you can send in your questions if they come up.
Absolutely. We're here for you. And so Paul will throw up a slide. Sorry. Okay. So we've got a code. Thank you for participating tonight. This will enable you to get a nice discount to try the products. So take a picture, maybe write it down. And then the last slide is gonna be Cosi.
Ooh.
I know, right? Isn't she cute?
Yeah.
Cosi Talks, 8:30 Wednesday nights. Facebook Live, everything limb loss. And she has amazing guests, all the heavy hitters in the industry, and wonderful topics. Excuse me. So check her out. And that's me. So please reach out. Anything we can do, we're here for you. And I will make sure Greg and Cosi help. So thank you so much for tonight. We appreciate your support and your participation, and take care.
Awesome. Thank you, Chris. Thank you, Cosi. It's good to see you, Cosi.
No,
Yeah.
my pleasure. And thank you, Bambi and Kelly. Thank you so much for chiming in.
Yeah, thank you all. That was awesome. Thanks for the information and the great questions. So,
All right.
Guys, have a great evening.